Hi, welcome everyone to the Transfusion Vitals channel. We are starting the new series of HDFN. So this is the part 1 of the hemolytic disease of fetus and newborn from the Transfusion Vital channel, and this presentation will cover the complete spectrum of the HDFN. Today we will be covering the types and classification, pathophysiology, sensitization and the immune mechanism of HDFN. So let's talk about the definition and the overview of HDFN. HDFN was historically called erythroblastosis fetalis because of the circulating nucleated red blood cells erythroblasts visible on the neonatal blood film, a consequence of extramedullary hemopoiesis responding to the severe anemia. Only the IgG, not IgM or IgA, crosses the human placenta via the FcRn, that is neonatal Fc receptor, on syncytiotropoblast cells. This is fundamental immunological reason why primary sensitization, which generates IgM, does not cause the HDFN, but the secondary response with IgG do. IgG1 and IgG3 are the most efficiently transferred and most hemolytically potent subclasses. Anti-D immunoglobulin prophylaxis introduced in 1969 has reduced Rh-HDFN by 90%, one of the greatest successes over the previous years in the preventive medicine. If we talk about the incidence, Rh-HDFN is 1 to 3 per 1000 live births, whereas ABO-HDFN affects 1 to 4% of neonates, but it is actually mild. HDFN can affect any gestation and tend to be worsened with each subsequent incompatible pregnancy because mammary B cells become increasingly primed. Next we talk about the Rh blood group system, and it contains 5 antigens which are very critical for the HDFN. Rh blood group system is the clinically important system in the transfusion medicine after the ABO. If we talk about the Rh negative, then there is a gene deletion, not a recessive allele, that is Rhd negative individual, approximately 15% of Caucasians, 8% Africans and 1% Asian simply lack the Rhd gene. This genetic basis is what enables the cell-free fetal DNA, we'll call now as cfDNA testing, which detects the Rhd sequence in the maternal plasma, confirms the fetal Rhd positivity. The RHCE gene, which encodes for both capital C small c and capital E small e antigen on the same protein. This is why anti-C often accompanies anti-D. Anti-small c is the most clinical significant non-DRH antibody. It can cause severe HDFN and requires the intrauterine transfusion and should be managed like anti-D. Whereas weak D typing requires the indirect antiglobulin test. Weak D type 1, 2, 3 are not a risk for sensitization, whereas partial D variant are at risk and should receive anti-D. If we talk about the frequency, 85% of the population is D positive, and in Rh negative women, approximately 60% of pregnancies involves an Rhd positive fetus, making systemic anti-D prophylaxis essential. So first type, that is Rh-HDFN. In Rh-HDFN, there is a Rhd negative mother which are sensitized by the Rhd positive fetal RBCs. This will produce IgG, anti-D, and these antibodies will cross the placenta in the subsequent pregnancies, which can destroy the Rhd positive fetal red cells, which can lead to hemolysis and anemia. So there can be a sensitizing event like amniocentesis, ectopic pregnancy, trauma, delivery. So in this, the minimum volume for the sensitization is approximately 0.01 to 0.1 ml of the fetal blood. At delivery, the average feto-maternal hemorrhage is 0.1 to 0.3 ml, but can be up to 30 ml in the rare cases. Then the second is the first pregnancy, which is usually ineffective because the primary immune response generates the IgM, which cannot cross the placenta, but the mammary B cell will form silently. Now this is the critical exception, that the woman which is RHD negative, might get the transfusion with the RHD positive, and then it can lead to the HDFN. Titer and the severity, if we talk about, then the critical titer of more than 16 will trigger the fetal medicine referral. However, the titer is imperfect to predict the severity. Next is your FMH quantification, which can be done by the flow cytometry or the Claude-Hodgkin-Backe test. Then is the subclass of IgG. If it's IgG1 or IgG3 are the most efficiently transferred by the FcRn receptor and are most hemolytically potent. IgG3 has the highest complement fixing capacity but has a short life of 7 days versus 21 days of IgG1. Next is the ABO-HDFN. ABO-HDFN is important entity to understand because it is common and usually benign but occasionally cause significant neonatal jaundice. The mechanism includes the group O mother have naturally occurring IgG, anti-A and anti-B antibodies in addition to the IgM. These are non-immune. They arise without the prior exposure. The IgG component crosses the placenta and coats the fetal red cells in a group A or B infant, which can lead to the HDFN of ABO. So these are very milder than the RHDFN as A and B antigen are widely expressed on many tissues and the antibody is diluted across many targets. Fetal and neonatal RBC express fewer A and B antigen sites than the adult cell, therefore there is a weaker coating. And ABO antibodies can fix the complement less efficiently than the anti-D. On the blood film, you can see the spherocytes on the blood film, unlike the RHDFN, which shows the polychromasia and the nucleated RBC. Weakly positive or even negative DAT can be possible as cells are lightly coated. So elution studies are essential. The elute from the cord blood cells will react with A or B cell, confirming the diagnosis. In the first pregnancy, if it is affected, the key point is that unlike RHDFN, which spares the first pregnancy, ABO-HDFN can affect the first baby because the IgG, anti-A, anti-B is naturally present. Next is the CAL-HDFN. CAL-HDFN is the single most important special case in HDFN. It has a unique mechanism that distinguishes it from the all antibody mediated HDFN. All other alloantibodies cause HDFN purely by hemolysis. Anti-K does something additional. It suppresses the erythropoiesis. The K antigen is expressed on the erythroid progenitor cells, that is BFUE and the CFUE in the fetal bone marrow and the liver. Anti-K antibodies bind to and destroy these precursors, preventing new red cell population and its production. So it leads to the severe anemia development with the disproportionately low bilirubin. Reticulocytes count is paradoxically low despite severe anemia. So what we can do, you cannot rely on the bilirubin on the titer to assess the severity in the CAL-HDFN. MCA PSV Doppler monitoring is mandatory regardless of the antibody titer. The critical titer for the CAL-HDFN is more than equal to 8. The sensitization in this case, 90% of the anti-K sensitization is from the blood transfusion. That is, K antigen is highly immunogenic, 10% risk per exposure. That is why K negative blood should be given to all the women of childbearing potential according to the BCSH recommendation. Other antibodies like anti-small c is the most significant non-D. Non-CAL antibodies, it can cause hydrops fetalis and must be managed with the same urgency as anti-D. So we'll talk about the pathophysiology. The first part is the sensitization. The sensitization mechanism is the immunological foundation of the HDFN, and understanding this will explain why the first pregnancies are usually spared. So step 1. Even the physiological microhemorrhages in the late pregnancy transfer small volume of the fetal blood. Most significant sensitizing event, delivery, which average of 0.1 to 0.3 ml of feto-maternal hemorrhage. So the critical threshold for the primary sensitization approximately 0.01 to 0.1 ml. Step 2 is a foreign RBC antigen which are phagocytosed by the maternal dendritic cells and the macrophage, processed into the peptide fragments and presented on the MHC class II molecules to nate CD4 plus T helper cells in the secondary lymphoid organ. Step 3 is the primary response, which is generated mainly by the IgM, a large pentameric molecule that cannot cross the placenta via FcRn. This is why the first pregnancies are usually unaffected in Rh-HDFN, whereas memory B cells and the long-lived memory T cells are formed at this stage. So step 4, in the secondary response, that is on the re-exposure, next incompatible pregnancy, memory B cells are rapidly recalled. They undergo the class switching to produce IgG1 and IgG3, small monomeric molecules efficiently transported across the placenta. So the important thing is the ABU incompatibility between mother and the fetus provides the partial protection against the RA sensitization, and ABU incompatible fetal RBCs are rapidly cleared by the maternal anti and anti-B before they can sensitize the immune system. The part 2 is the IgG placental transfer. The FcRn neonatal Fc receptor or Bram-Bell receptor is a key molecular mechanism enabling the HDFN. So at term, fetal IgG concentration exceeds the maternal level. The FcRn acts as an active pump. It binds IgG at the acidic endosomal pH, transport it through the trophoblast cell by the transcytosis and releases it at the neutral pH on the fetal side. This requires the energy and are saturated. Even the low maternal antibody titers can cause a significant fetal harm, especially with the high affinity IgG3. HDFN worsens in the third trimester as FcRn transport increases. If we talk about the subclasses, then IgG1, most common class of anti-D and anti-K, efficiently transferred and hemolytically potent, whereas IgG3 is highly hemolytic potency but having the short life. IgG2 is poorly transferred and having the low potency, and IgG4 moderate transfer but low potency may cause the less hemolytic. The consequences is the cascade from the antibody coated RBC proceed through the extravascular hemolysis, lead to anemia, compensatory erythropoiesis, hepatosplenomegaly, portal hypertension, and then hypoalbuminemia lead to high drops. So bilirubin is removed via placenta in utero but accumulates postnatally. Part 3 is the hydrops fetalis. Hydrop fetalis is the clinical endpoint of untreated severe HDFN. So we have to understand the cascade, which is essential for appreciating why timely intrauterine transfusion is life-saving. So in this, the severe anemia where the hemoglobin drops less than 5 to 6 gram per deciliter, critically anemia from ongoing hemolysis that outstrip the compensatory erythropoiesis. Then it will lead to high output cardiac failure. The heart compensates for reduced oxygen delivery by increasing the cardiac output. Eventually the myocardium fails, and this is cardiomegaly on the ultrasound is visible. Extramedullary hematopoiesis by the liver and spleen lead to massive enlarge of these organs, and this compresses the portal system, lead to the portal hypertension. Followed by hypoalbuminemia, that is the portal hypertension reduces the hepatic protein synthesis, albumin falls, so there will be drop in the oncotic pressure. Step 5 is the capillary fluid leak. When the oncotic pressure falls below the hydrostatic pressure, fluid moves into the body cavity and ascites forms the first. And the last is the hydrops, that is fluid is accumulated in more than or equal to 2 compartments with generalized edema, that is anasarca, pre-terminally without intervention. The important point is, if we do the MCA-PSV Dopplers before the hydrops deliver, then if the MCA-PSV is more than 1.5, multiple of mean is detected and acted upon the promptly with the intrauterine transfusion. High drops can be prevented entirely, and the high drop should not be the first sign of severe HDFN if monitoring was adequate. Now we have to understand the bilirubin metabolism in the neonate, which is essential to appreciate why HDFN causes dangerous jaundice in the neonate. So bilirubin metabolism, there is a problem in the neonate. In the fetal life, bilirubin crosses the placenta and is conjugated by the maternal liver. After birth, the neonatal liver must suddenly conjugate all bilirubin itself. In HDFN, massive hemolysis floods the liver with the unconjugated bilirubin. It cannot conjugate fast enough. There are two compounding factors. UGT1A1 enzyme activity is low in the newborn, which matures gradually over the first week of life. Second is the enterohepatic recirculation. Intestinal beta-glucuronidase deconjugates the bilirubin back to the unconjugated form, amplified in the neonates not feeding well or with the delayed meibomian process. There is one Bhutanese normograph. So HDFN baby should always be classified as high risk. Use the lowest applicable threshold line on the NICE or the AAP chart. Transcutaneous bilirubinometry unreliable during the phototherapy. So in this, the blue light pitches the skin bilirubin and gives falsely low TCB reading, that is the transcutaneous bilirubinometry reading. Always use the serum bilirubin in the HDFN patient. How we can prevent the connectors? So if there is a rate of rise more than 8.5 millimole per liter per hour, then there is an urgent action required. Albumin bilirubin ratio, that is BAR, bilirubin to albumin ratio more than 8 mg per gram indicates risk of free bilirubin crossing the blood-brain barrier. Hypoalbuminemia dramatically lowers the safe bilirubin threshold. So this was all about the today's session. Thank you so much. If you found the video informative, like, share and subscribe the channel. And until the next time, stay curious, careful, keep saving life. This is Transfusion Vitals signing off.